Bismillahirrahmanirrahim. Good day, everyone, and thank you for being here. Today, I'm going to walk you through a very interesting and clinically challenging case. This is a young man who presented with nephrotic syndrome, which by itself already opens a broad differential. But what makes this case more interesting is the presence of facial rash adding an important systemic clue. So the key question here is, are we dealing with a primary renal disease, or is this a part of broader systemic process? And how do we connect the dots between heavy proteinuria and dermatological findings in this young patient? In this case, we will focus on building a structured approach to nephrotic syndrome in young adults. We also highlight how extrarenal manifestations like skin findings can completely shift your differential and management. Let's start by breaking down the clinical presentation step by step and see where it leads us. I'm Dr. Mahmoud Al-Sheikh, nephrology consultant and World Kidney Academy educator. So let's get started. This is a 35-year-old man, previously healthy, with no significant past medical history. A few weeks prior to presentations, he had an acute febrile illness, and he was treated by antibiotics. Shortly after that, he developed new-onset lower limb edema, which progressed over about 10 days. At this point, in a young patient with recent infection followed by edema, we already start thinking about glomerular disease. Now, looking at his labs, the picture becomes very striking. He has massive proteinuria with a urine protein creatinine ratio 10.9 grams per gram. His serum albumin is severely reduced at 1.3 grams per deciliter. So this clearly establishes nephrotic syndrome. But what really raises concern here is the presence of extensive thrombosis, specifically involving the left renal vein with extension into IVC and the iliac system. And as we know, nephrotic syndrome creates hypercoagulable states, but this degree of thrombosis is quite significant and should always prompt deeper evaluation. His serum creatinine is mildly elevated at 1.4 milligram per deciliter, suggesting earlier impact on kidney function. So to sum up this slide, we are dealing with a young patient with new-onset nephrotic syndrome, severe hypoalbuminemia, and major thrombotic complications following a recent infection. The key question now becomes, what is the underlying etiology and how does this all connect, especially if we add the extrarenal features we will discuss. The next slide. Now let's take a closer look at the lab evaluation, because this is where the picture really becomes together. Starting with the blood work, his hemoglobin is 9.9 grams per deciliter, so he has mild anemia. White blood cells and platelets are within normal limits, which makes an active systemic inflammatory or hematological process less likely at this stage. His creatinine is 1.4 milligram per deciliter, slightly elevated, suggesting earlier kidney involvement. Sodium is low at 131, most consistent with dilutional hyponatremia in the setting of severe nephrotic syndrome. And importantly, his serum albumin is profoundly reduced at 1.3 grams per deciliter. The level of hypoalbuminemia is severe, and it explains both the edema and hypercoagulable states we are seeing in this patient. Now, moving to the urine studies, the protein to creatinine ratio is 10.9 grams. That clearly in the nephrotic range and actually on the very high end. Urine microscopy shows no active sediment, no hematuria, no casts. So this is a planned urine sediment, which is key clue. Points us more toward podocytopathies or membranous process rather than inflammatory glomerulonephritis. So putting this together, we have the full nephrotic tetrad, massive proteinuria, severe hypoalbuminemia, edema likely, hypercoagulability, and in addition, the mild creatinine rise and hyponatremia suggest a more severe or advanced presentation. At this point, imaging becomes critical, especially given the concern for thrombotic complications, and the next step will be narrow down the underlying cause of his nephrotic syndrome in young adult. So now we are moving to the most decisive part of this case, imaging and renal biopsy. This is where everything starts to come together. Vascular imaging with ultrasound and contrast-enhanced CT shows a very striking picture. This is complete thrombosis of his left renal vein. In addition, there is partial thrombosis involving the inferior vena cava, the inferior mesenteric vein, and the left internal iliac vein. We also see collateral vessel formation, which suggests that this process is not entirely acute. This extensive thrombosis severely and strongly reflect hypercoagulable state. And in nephrology, when you see renal vein thrombosis, especially with very low albumin, membranous nephropathy should immediately be high on your differential diagnosis. Severe nephrotic syndrome leads to urinary loss of anticoagulant protein like antithrombin 3, along with increased hepatic synthesis of procoagulant factors. This creates perfect setup for extensive venous thrombosis. Now let's move to biopsy findings. On LM, the silver stain, the capillary loops appear open without double contours, spikes, or holes at this stage. On a Mason trichrome stain, there are subepithelial deposits along the outer aspects of glomerular basement membrane, and importantly, immunofluorescence shows granular IgG positivity along the capillary loops. This classic pattern, subepithelial deposits with granular IgG staining, is diagnostic of membranous nephropathy. So putting everything together, the final diagnosis is, in this case, membranous nephropathy. And importantly, this explains both the severe nephrotic syndrome and the extensive thrombotic complications. The next step now to determine whether this is primary or secondary membranous nephropathy and to guide targeted management accordingly. So now that we have established the diagnosis, let's move into initial management. And this is really guided by risk stratification according to KDIGO guidelines. This patient clearly falls into the very high risk category that's driven by three major factors. First, he already has significant thrombotic event. Second, he has severe nephrotic state with massive proteinuria and profound hypoalbuminemia. And third, there is evidence of reduced kidney function with a rising creatinine. So this is not a patient who can observe, this is a patient who needs active treatment. Now, given the extent of thrombosis, therapeutic anticoagulation is very essential. However, timing matters. In this case, anticoagulation was intentionally delayed for about 24 hours after the biopsy, and that's to balance the bleeding risk from procedure against the already high thrombotic burden. So anticoagulation was initiated safely 24 hours post-biopsy, aligned with KDIGO recommendations. Now moving to disease-specific therapy, the patient was started on a modified Botticelli regimen. This involves cyclical therapy over 6 months. Month 1, 3, and 5 are steroids. Month 2, 4, 6 are cyclophosphamide. This regimen remains one of the standard evidence-based treatment for high-risk membranous nephropathy. But despite starting appropriate therapy, the story doesn't end here. In fact, just 1 week into the second month, the patient comes back with a new and striking development, and that's where the case takes an important turn. About 1 week after switching from steroids to cyclophosphamide, the patient comes back with new symptoms. He develops painful inflammation and ulceration of lips, consistent with cheilitis. At the same time, he has rapid worsening oral lesions. These become severe enough that within a few days he is unable to tolerate oral intake. So this is not mild mucositis, this is progressive and clinically significant. In addition, he develops hyperpigmented mother rash. This rash is painless and distributed over the cheeks and forehead. And importantly, this rash becomes more apparent after steroids were withdrawn. So now we need to step back and reassess. We have a patient with nephrotic syndrome and immunosuppression who now presents with severe oral lesions and a facial rash. If this is drug-related complications or any opportunistic infection, or are we unmasking an underlying systemic disease? The rapid progression and severity, especially the inability to eat, makes this an urgent clinical situation. So the next step is to build a focused differential diagnosis and identify what ties all these findings together. So now we ask the clinical question, what further tests are needed to determine the etiology of this rash? And remember, this happening in a patient on immunosuppressive therapy, which significantly broadens the differential. At this point, we need to systemically rule out the most likely and most dangerous possibilities. First, we consider herpes labialis. This is particularly important in immunosuppressed patients, where HSV can present more aggressively. So we check HSV, IgM, and IgG serology, and ideally obtain smear from the lesion. In this case, these tests come back negative. Next, we think about drug hypersensitivity, especially related to cyclophosphamide. The timing fits since the symptoms started shortly after switching therapy. So the logical step is to stop all suspected offending agents. Cyclophosphamide was discontinued. However, the rash continued to progress, which makes this diagnosis less likely. Differential 3 bacterial. Third consideration is bacterial cellulitis. Given the severity of lesions, blood cultures were obtained and empiric broad-spectrum antibiotics were started. But cultures remained negative, and there was no clinical response to antibiotics. So now we have ruled out the three major categories: viral, drug-related, and bacterial. And when a rash doesn't respond to these initial approaches, especially in a patient with systemic disease, we need to think beyond the obvious. This is where the case pushes us to consider a deeper unifying diagnosis that can explain both the renal disease and these new systemic findings. So at this point, infection and drug reaction have essentially been excluded, and importantly, the rash seems to worsen after steroid withdrawal. That combination should immediately raise suspicion to an underlying autoimmune process. Now, one way to approach this is to revisit the biopsy and ask, are there features suggesting secondary membranous nephropathy? We look at for mesangial or endocapillary proliferation on light microscopy. We check for additional immune staining like IgA, IgM, or C1q on immunofluorescence. We also look for mesangial deposits or subendothelial deposits on EM. And in some cases, tubular reticular inclusions can point toward interferon-driven disease like lupus. But in this case, none of these features were present, and electron microscopy was not performed. So histology doesn't strongly support a secondary cause, but also it doesn't completely exclude it. This is where antigen-based classification becomes very useful. First, PLAR2, which is the most common antigen in primary membranous nephropathy, was negative. Second, NIL1, which can be associated with malignancy-related membranous nephropathy, was also negative. That leaves us with extosin 1 and 2. So positivity of this is often linked to autoimmune disease, particularly lupus-related membranous nephropathy. And in this case, those results are still pending. So now we are in a situation where primary causes are less likely, infection, drug reactions have been excluded, and the clinical picture, especially the rash, steroid responsiveness, is pointing toward an autoimmune etiology. So the next step is to confirm whether this indeed a lupus-associated membranous nephropathy or it's another autoimmune process. So this is a turning point of this case, the moment where everything starts to align into a single unifying diagnosis. Paraffin immunofluorescence revealed extosin 1 positivity along with the glomerular capillary walls. This is a critical finding. Extosin 1 and 2 positivity strongly point toward an autoimmune associated membranous nephropathy. And the most common, this is linked to lupus. However, this finding alone is not diagnostic, must be interpreted in context of serology, clinical features. So we move to lupus and connective tissue disease serologies. Complement levels are essentially within normal range. C3 is normal, C4 is actually elevated, not decreased. ENA is strongly positive at 1 to 100 with a 4+ speckled pattern. Anti-double strand DNA is negative, but importantly, there is strong positivity for anti-RNB and anti-SM RNB antibodies. Anti-SM antibodies also highly, slightly elevated. SSA and SCCB are negative. So what does this mean? Despite the negative double-strand DNA and the normal complements, the combination of a strong NA and high RNB and SM RNB titers strongly support an autoimmune connective disease process. This cause represents lupus or possibly an overlap syndrome such as mixed connective tissue disease. Now, when you connect this with extosin 1 positivity on biopsy, the nephrotic syndrome and rash that worsens after steroid withdrawal, the pictures become highly suggestive autoimmune disease membranous nephropathy mediated. So not all lupus nephritis presents with low complements or positive double-strand DNA, and relying only on classic markers can lead to missed or delayed diagnosis. So now the focus shifts toward confirming the autoimmune diagnosis and tailoring immunosuppressive therapy accordingly. So now we can bring everything together into a final unified diagnosis. This extosin 1 positive membranous nephropathy consistent with class 5 lupus nephritis. And this diagnosis is not based on a single finding, but on convergence of multiple key elements. First, the histological pattern clearly shows membranous nephropathy, with subepithelial IgG deposition along the glomerular basement membrane. Second, the presence of extosin 1 positivity. This is a strong markers of autoimmune-associated membranous nephropathy, most commonly linked to lupus. And third, the serologic profile is strongly positive AMA, elevated anti-RNP and anti-SM RNB antibodies, along with compatible clinical features, including the rash. Even in the absence of classic findings like low complements or positive and double-strand DNA, this combination strongly supports a lupus-related process that is cooking. This case highlights that lupus nephritis can present with atypical ways, and that antigen-based classification, particularly EXT1 and 2, can be crucial in uncovering the underlying etiology. So the take-home message here is always integrate histology, antigen profiling, and serology, because the diagnosis often lies at the intersection of all three layers. So now the key question is, how do we treat this patient? And at this point, are we clearly managing class 5 lupus nephritis with membranous nephropathy? The patient was started on an induction regimen targeting an autoimmune disease. First, he received intravenous steroids, this to achieve rapid disease control in the acute phase. Then he was transitioned to oral prednisone, about 0.5 mg per kilogram per day, serving as a maintenance steroid therapy. Importantly, MMF at 2 grams per day was initiated. This replaced cyclophosphamide as a steroid-sparing immunosuppressive agent. And this shift makes sense, because now we are treating an autoimmune lupus-related process where MMF is preferred and well-established therapy. The patient was continued on MMF at 2 grams daily during the follow-up. And importantly, there was no evidence of ongoing systemic lupus activity at this stage. Now let's look at the response, which is quite impressive. Serum creatinine improved from 1.4 down to 0.6. Proteinuria dropped dramatically from 10.9 to 0.1. And serum albumin increased from 1.3 to 3.4. So this represents complete renal response within 3 months. This case highlights how identifying the underlying etiology, especially using antigen-based classification, as we mentioned, can completely change management and lead to excellent outcomes. The right diagnosis leads to right therapy, and in this case, a remarkable recovery was seen. So to wrap up, let's highlight a few key teaching points from this case. Period 1, when histology is silent, first reconsider your diagnosis. When histology is not fully explained, if a biopsy lacks classic features of secondary membranous nephropathy, antigen-based testing can be extremely helpful. Markers like Platoir, NEL1, especially EXT1 and EXT2, can reopen your differential and uncover an autoimmune etiology. Period 2, EXT1 and 2 interpretation. Positivity doesn't equal lupus by itself. These markers support an autoimmune-associated membranous nephropathy, but the diagnosis requires integration with serology and clinical features. Third, always reassess when the clinical course doesn't follow expectations. In an immunocompromised, immunosuppressed patient, a worsening rash that doesn't respond to antivirals or antibiotics, and that actually worsen after steroid withdrawal, should raise strong suspicion for autoimmune disease. And finally, therapy must be tailored to an underlying diagnosis. Reclassifying this case from primary membranous to lupus-associated disease, moving from ponticelli regimen to lupus, directly therapy with steroid and MMF, led to rapid complete renal response. So the key message is simple: integrate pathology, serology, and clinical evolution, because the correct diagnosis is what ultimately drives the right treatment and the best outcome. Thank you so much for watching. See you in the another lecture. Assalamu alaikum wa rahmatullahi wa barakatuh.